Hello, everybody, and welcome to our discussion on the Rural Health Clinic consolidations and base rates. So, when we talk about the rural health clinics or the RHCs, first of all, we have to understand that the original payment for these facilities, they were reimbursed on a cost per visit methodology. We're going to see that down below. That's sometimes referred to as the all-inclusive rate. But the idea here is that for this cost per visit, you would take the total costs divided by the total visits from the cost report. Both of them are from the cost report. And that would give you a rate that would then be multiplied by the Medicare visits. That's the cost per visit rate that would then be multiplied by the Medicare visits. Now, one thing to note here, there is another separate mechanism called the productivity standard. That's found on worksheet M-2, which we'll see in a little bit. And the way this works is that if for the number of FTEs the provider has, the RHC has, if they don't hit a certain required number of minimum visits, then their total visit count is bumped up to that floor. So, of course, with this calculation here, if you increase total visits, all other things equal, your rate is going to drop. You saw the same total costs, but they're spread out over more visits because of this proxy, this productivity standard. So that's a separate mechanism, though, separate from the rate itself, although it influences the rate, obviously. And the other thing about this is, depending on the type of facility, the type of facility, we'll see that in a bit, this rate is subject to a national per visit limit, basically a cap, and this is updated annually. Now, this calculation for the visits, the cost per visit, and the multiplication of the Medicare visits, that takes place on worksheet M-3, which we're going to see in just a bit. So we have two worksheets here, M-2 and M-3. Here's M-3, and you can see here that we have the total cost. This comes from M-2. The total cost for all these services, there are some injections, that's another type of cost. So line 3 sums up the total allowable costs, excluding those injections or infusions from line 2. So here's the total cost, and it's going to be divided by the total visits. Again, line 4. Now, I want to stress here that this total visit count, as I said earlier, was subject to the productivity standard potentially. So if there was an impact, that would already be showing up right here. This is M-3. The productivity standard is on M-2, so you can see that the total visit calculation is on M-2. Now, there's also an adjustment to the visits. If you have some physicians' visits under agreement, you might be adding those in because the cost is up here, so the visits need to be up here. But in any case, you get the total adjusted visits. So we have kind of an adjusted cost, total cost divided by a total adjusted visits, and you get your adjusted cost per visit. If there was no cap or nothing like that, this is what the facility would be reimbursed for every Medicare visit. Of course, as we said, depending on the facility, depending on the situation, you're likely subject to a per visit limit. And in this case, the facility is. Notice it's a calendar year limit, so it changes at 1/1, increases just by the nature of it for inflation. So since both of these were lower than the cost per visit, this ends up being what is used. Now let's say this limit was, 1,000 for both years. Then this 919.41 is what would flow down to be the actual rate that's used. So that, of course, is multiplied by the Medicare visits down here, line 10, and these come from the PSNR, by the way. They're Medicare only. And this would arrive at the actual program cost or Medicare cost that's allowable. So that's how the M-3 basic mechanism works. M-2, as I said, it's the calculation of the visits. So what's happening here is you take a look at your different types of positions, physician, physician assistant, nurse practitioner, there might be some subscripts, and you look at the FTEs that the facility has. Now, what happens here is there's a productivity standard. Normally, it's 4,200 for a physician, 2,100 for a mid-level practitioner, basically everything non-physician. And that's normally what you'll find in here. However, I do want to stress there is one time you'll find something, well, there's two times you'll find something different than those two numbers. One of them is obviously if they did indeed have a productivity standard exception, because there's a process in place for that as well. That's on the next slide. So that would override the 42 or 21. These are input numbers. That's the key thing to note. We have to review them at the time of final settlement, so it's important to make sure you as a provider put those in properly up front to know what your proper interim reimbursement is going to be. But in any case, it's 4,200, 2,100, unless there is an exception, which we'll see in just a bit. That's actually worksheet S-8 records whether or not there is an exception. S-8 is just kind of a control question worksheet. So that's what's going on here. And generally, it's not going to be 0. It's usually going to be something like 1, unless there's a different number that you qualify for. Maybe you just qualify for a half reduction instead of 2,100, which is what it would normally be here. Maybe you'd get 1,050. It just depends on the documentation you submit, all of that. So what normally would happen is that the number of FTE personnel would be multiplied by the productivity standard to identify the minimum visits. Now, unfortunately, this, just due to rounding, 0.18 multiplied by 1 is less than 1 visit. That's why you're seeing 0 here. If you saw it unrounded, it would actually be 0.18 here. Of course, that's the number. So it is technically, it's establishing a minimum visits, but their total visits were 168, so that ultimately is what's being used. If the minimum visits are indeed higher than what the total visits show, then this number will be higher. So it brings it up to the minimum visits. That's the point. But the other thing I wanted to mention, there's one other way this number would be less than 4,200 or 2,100, or possibly more. And that is when you have a non-standard cost reporting period, less than or greater than 12 months. This standard, the cost report currently does not automatically prorate these. It's unfortunate. So you technically would need to prorate this with the proper number. Let's just say it was a 6-month period instead. This should be 21 and this should be 1,050 in that situation. Otherwise, it's not going to apply properly. So there are your productivity standards, how the visits are calculated. That 151 is what we saw over here. Or actually, I'm sorry, let me go back here. The 168 was what we saw over there. The 151 is the physician services under agreements. Both of those numbers showed up. That's the key thing there. So, as I said, there is an exception. There's ability to be, well, I said earlier, there's ability to get an exception from the productivity standard itself, the RHC productivity standard. You just need to submit the documentation, and let me show you that here. That would be found on our WPS website. Of course, the audit section, and specifically the RHC or Rural Health Clinic section. We have two different articles we're going to talk about here. This one in particular is the productivity standards exception. So there it basically gives you an overview of the exception. It points to the old Federal Register way back in 1982 that first identified the process for requesting an exception. Now we have a checklist here that walks you through the steps, the types of documentation we might expect for this, the types of reasons that might work. As far as a time frame, there's not an actual time frame. You could technically do it before, you could do it after. You could even technically do it through a reopening if it's still timely enough to do a reopening. That's the one exception there. However, in order to have this done and included in your tentative settlement, included in your final settlement, we recommend that you submit the request prior to 60 days before your cost report submission. That should give us enough time to do it on our side and get the response back to you, whether it's approved or denied. Occasionally we'll get requests just a few days before somebody's trying to submit a cost report, and unfortunately we can't guarantee that. We have a very big queue of workload for these and other types of requests, So if you submit it like even a week prior to, we're probably not going to be able to get to it by the time you submit the cost report. So we recommend 60 days. 30 days might work, but that's still starting to push the limits there. But in any case, you can submit those requests to this email address here, and we do recommend via email rather than hard copy. Email is just much more efficient. We can respond very quickly with a confirmation, and we have a checklist here that you can walk through to complete that. It's not a required checklist, but it's a good thing to use just so both parties know what you're trying to request. This, by the way, is completely up to the MAC discretion at this point, but again, we're looking for that type of justification and documentation. So on to the next one, and we're going to see that next article in just a second. The next exception is an exception to the cost per visit limit. So, and again, we're talking a little bit about the old RHCs, although some of that carries into the current status, and we'll see that in just a bit. But this exception is if an RHC is provider-based to a hospital, so they're a unit of a hospital, and the hospital has fewer than 50 beds. That's a key thing to note. This 50 beds has nothing to do with the RHC itself. It's the hospital has fewer than 50 beds. So it's a small hospital that also has an RHC attached to it. They're exempt from this national limit that would otherwise apply, and instead, for the older units, they could just use the full cost per visit. And again, though, I want to stress there's a fairly recent change that all RHCs have phased into, and that's what this article and discussion is all about. But let's go back to this exemption. Exemption from the 50 beds, or from the limit if you have a hospital with fewer than 50 beds. The second article is about alternative ways to be exempted from the limit. So that is our other article here. And here we have the per visit limit exception. So this just gives you a little bit of an overview. And in 1998, CMS established an alternative exception. Rather than the 50 beds, it's based on average daily census. So the idea is there might be hospitals that had to have enough bed size because there might be seasonal fluctuations. They might need more than 50 beds kind of capacity, but their utilization it fluctuates quite a bit. They're in very rural areas. So the idea here is if the RHC or if the hospital has an average daily census that does not exceed 40 people. So in other words, they might have more than 50 beds, but if no more than 40 of them are used on average, average daily, and so that's the first thing, and they had to be located in extremely rural areas, which were initially defined as the 8-level or 9-level UIC code, Urban Influence Code. But in 2008, they switched that. They said, we're not using the UIC anymore. We're using the RUCA, Rural Area Commuting Area codes. Or, I'm sorry, that should be Rural Urban Commuting Area codes. So the thought here, this is in the Federal Register, but it was never finalized. So it was never put into regulation. However, CMS still has the ability to use policy-making authority, and they did update the manuals to use that. So they switched to the RUCA codes in effective March 1, 2013. So the point is, if you're in a hospital that has less than 50 beds, then hey, you're fine. If you're in a hospital that has more than 50 beds, you can check to see if you meet this criteria. And again, you'd want to submit that documentation. That's the key thing. We would need to know that average daily patient census, and we would need to know what RUCA code you qualified for, which, by the way, those are detailed in the policy manuals, so you can see the links to that. Otherwise, when we do the cost report, we're going to be applying that national limit. So now we're moving on to kind of the main topics for this discussion, the consolidation and the new base rate calculations. So RHCs. First of all, consolidation has been around for a very long time. And the idea here is if a hospital has multiple RHCs, it can be a little tedious to fill out the M series and the worksheet S-8 for all these different RHCs. And of course, you'd even have to fill out several lines of worksheet A, B, B-1, all of that. So it can be tedious, extra documentation. For administrative simplicity, CMS has allowed for the ability to elect consolidation to report all those RHCs as one large RHC on the cost report. Now that is the key thing. This is just for cost reporting purposes only. All those RHCs individually still have to bill under their own individual provider numbers. There will still be a PSNR for all those individual provider numbers. Everything will be lumped together when the report is consolidated. And the key thing, again, it's an election. You can elect it, then you can elect to go back to non-consolidated if you like. But the point is, this must be elected. Either way must be elected in advance of the cost reporting period. Now, technically, there's no specific time frame. So, the earlier the better, certainly. But if it was a day before, technically it would be allowable. So that's the one thing I wanted to mention there. It just needs to be an election that comes into our audit supervisors, and then this can be reviewed. It's not really reviewed, just documented and noted. There's no review/approval needed. It's just we need to receive the election. So here is the information. Now, by the way, notice this red information was updated fairly recently, a little over a year, well, about a year and a half ago. So first of all, the original verbiage says RHCs and FQHCs with more than one site, more than one RHC, may file consolidated cost reports if it's approved by the MAC in advance of the cost reporting period. And again, approved is kind of a strong word there. We just need to receive it. And it needs to be a fully submitted request. So I guess we could reject it if it wasn't a clear request or anything like that. But it has to be in advance of the cost reporting period. Once having elected to use a consolidated cost report, you again have to elect to revert back. You won't be able to just automatically revert back. It has to be, again, quote unquote, approved. So now, the change here, this was due to a change in the legislation from Congress, change in the statute for new RHCs on or after January 1st, 2021. We're going to see a payment rate difference, a significant difference in how they're handled. But for these facilities, you can still file consolidated cost reports. These new RHCs can still file consolidated cost reports, but not with any old RHC. It has to be either with new RHCs that are provider-based or new RHCs that are independent if you're filing an independent cost report for an RHC, or existing independent RHCs. Because again, the whole point about independent is there was no exception from the limit. The exception from the limit only applied for hospitals under 50 beds. So the point we're trying to make here is that the new RHCs can only consolidate with those that were not exempt from the limit. That's the point. So the final line here, you could also consolidate with existing provider-based RHCs as long as they're in a hospital with more than 50 beds, because then they're not exempt from the limit. And here what they're saying is specified provider-based RHCs, they should have specified this further, are not allowed to file a consolidated cost report with a new RHC. The specified RHCs are those with less than 50 beds, because then they would be exempt from that limit, and there's a difference in payment. That's the point we're trying to make here. So we'll get to that when we get to the rates in just a bit, but I just wanted to make a point that you can't consolidate with whatever RHC you want, and we'll even dig in deeper. It even depends on what year of a base rate was used. I know the policy manual doesn't get to that level of detail, but that's also important, and that's based on CMS clarification recently. So if we take a look at Worksheet A, line 88 specifically is where the hospital-based RHCs go. And the standard rule is if you have more than one RHC, you subscript that line. However, we know that, I guess this is just, this middle part's not all that important. It's just additional information about how to report the costs. So S8, worksheet S-8, line 13. This is what I was getting at earlier. I mentioned it has that, if you look at line 12, have you received an approval for a productivity standard exception? There's that question, but then there's also the consolidation question. And it's actually line 13 and the subscript, 13.01. So first of all, is this a consolidated cost report? Do you have more than one RHC reported in one line? And if it's no, then of course every RHC is going to have its own line. If it's yes, then you have to enter the number of RHCs included, which would be line 2, or column 2. And that's what we have to do there. And here, line 13.01 is the new requirement. The rule used to be all or nothing. Every single RHC could be consolidated, or none of them can be consolidated. You can't choose to consolidate half of them and leave the other half unconsolidated. But now with the new payment provisions that we're going to be talking about, basically the grandfathered RHCs that were exempt from the limit, and they'll still be exempt from, well, that limit at least. So the grandfathered RHCs, and when I say exempt from, I should say exempt from the national payment amount. That's a better way to put it now. So we have the grandfathered RHCs versus the new RHCs. And even the new RHCs are going to have two different groups, generally two, depending on what base year they're using. So line 13.01 is asking whether there are multiple consolidated RHC groups. So, for example, do you have a group of grandfathered and a group of non-grandfathered? You can have two consolidated groups. And if that's the case, what it's saying, if yes, enter in column 2 the number of groupings you have, and you have to complete a separate worksheet S-8 for each consolidated group. This is S-8. You're going to have another S-8 when this is answered 2 or 3. It's a very unusual mechanism. Usually the S-series worksheets don't have duplicates of themselves, but that's exactly what would happen here. The reason is that each S8, each consolidated group, would have to have a list of all the RHCs grouped together within that consolidated group. And again, every RHC line on worksheet A must also have a worksheet S-8 and M series. So again, what we're saying is if you had two consolidated groups, worksheet A is going to have two different cost centers to be used. And they're going to have their own S-8 and of course their own their M series. So as far as the M series, M-1 resembles worksheet A on the hospital cost report. It's the working trial balance, but specifically M-1 is just the RHC, so it breaks down the detail of what was on the worksheet A RHC line. Worksheet A is just a roll-up of the entire RHC costs. M-1 breaks it down into various types of RHC costs. M-2, we talked about that. That details the visits and productivity standard. And then, of course, M-3, we talked about dealing with the cost per visit calculation and the final settlement. So here's M-1. It looks very similar to worksheet A. The costs, reclassifications, adjustments, all the way down. And now what we're talking about here is the actual change to these payment rates. This worksheet, or this URL here, CMS's Medlards Matter article, the Consolidated Appropriations Act of 2021, it did a lot of things, but this is one of the things it did. It changed how RHCs are reimbursed. This is for RHCs beginning 4/1/21. So the legislation took effect technically January 1st, but the rule, the payment change took effect 4/1/2021. We'll see in a bit what that means. So there's a national RHC payment limit per visit. Again, there was before, but the big difference is now it's predetermined and it's a locked-in limit. They give us an 8-year period so far. That may very well be changed by Congress in the future. So 2021, it started at $100, and it's been inflated ever since, all the way to 2028. So when I said this took effect 1/1/21, it basically was for any RHC that was established on or after 1/1/21, or any RHC that wasn't exempt from the limits. So again, if there's a brand new RHC, then of course there's no way they can be exempt from the limits. There's no new grandfathering provision. Even if you have a brand new RHC that's hooked up to a hospital with under 50 beds, they can no longer be exempt from the limit. So that under 50 beds no longer works for brand new hospitals established on or brand new RHCs established on or after 1/1/21. Now again, those that were, let's say you have an old RHC that's been around for a while, but it was in a relatively large hospital that had more than 50 beds. So applies to those that weren't associated with a hospital under 50 beds. In other words, they are associated with a hospital with more than 50 beds. They were never exempt from the limit before, and they're not going to be exempt from the limit now. In fact, they're going to use this new limit. But again, these rates were effective for services provided on or after 4/1/21. So there was a few month gap before the rates kicked in. Those are new, what we call new RHCs. We'll dig into that a bit deeper in a bit. But the grandfathered RHCs are the ones that were in a hospital prior to 12/31/20, and the hospital had less than 50 beds. So the idea is they were exempt from the limit, exempt from the national limit before. They just used cost per visit. It's not quite going to be the same now, but they're at least not subject to the national limit, the federal limit. Now, as long as that hospital continues to have less than 50 beds, they will continue to have their grandfathered status. You can change addresses, you can change ownership. That does not result in the provider losing their grandfathered status. Here's a Federal Register that discussed that in more detail. But if the bed, even temporarily, barring, by the way, any sort of, like the COVID or any sort of national emergency where Congress or CMS may waive the limit, but barring that, if the hospital bumps above 50 beds, you're going to lose your grandfathered status and there would be no going back to it. You'd revert to the national rates just like the new RHCs. So that's the key thing to note there. Now, here's the thing. I said they're exempt from the federal limit, the national limit, but they're not exempt from a limit period like they were. So it's still a change from how they used to be treated. They're no longer exempt from all limits. They're just exempt from the national limit. So the way the new limit is basically a base, it's a hospital-specific limit is what it is. Very similar to sole community hospitals, Medicare-dependent hospitals, how their cap or their payment amount is based on an older year that's inflated forward. It's the exact same concept with the RHC. Specifically, the limit that's established for the grandfathered RHCs initially for 2021, it's going to be the calendar year 2020 base year cost per visit. So just look at that cost report period in the beginning of calendar year 2020, find their cost per visit, and then multiply it by a calendar year 21 update factor. Now the reason we're multiplying it by that update factor to get it to 2021 is so that it can be compared with the national 2021 RHC per visit limit of $100. So let's say that the calendar year 2021 cost after being inflated forward, let's say that was only $90. Then, of course, you don't want to be subject to a lower limit than new hospitals. That wouldn't make sense. So your limit becomes the national limit, and you're essentially in the same line as all new RHCs. But it's better than where you would have been with the cost report calculated base year cost per visit. Chances are it's going to be the exact opposite, and your base year cost per visit is probably going to be a bit higher than $100, potentially, and that is what gets locked in and inflated forward for future years. But now let's take a look at 2022. So we would look at the calendar year 2021 base year cost per visit. Again, we originally used 2020, now we'd be using 2021. multiplying it by the calendar year 22 update factor to get it to the next year, so that we can compare it again to the national calendar year 2022 RHC per visit limit and see which one is higher. That's the payment limit for that next year. Now, here's the thing about this. If you didn't have costs in 2020, because remember back here you needed to have costs in 2020, if they didn't have costs in 2020 for some reason, keep in mind they would have had to have been in existence by 12/31/20 at least, before 1/1/21, so they would have had to have been in existence at least, but maybe they didn't have costs for whatever reason. So in that case, there's nothing to use 2020, there's nothing in 2020 to use, so we'd have to skip forward and use 2021 as the base year. Otherwise, again, that 2021, or if there's no 12-month cost report in 2021, then we'd use the next available 12-month cost reporting period, and that becomes the base year. Again, keep in mind, the RHC had to have existed by 12/31/2020, but they may have just barely been starting, hadn't provided any services, didn't have any cost yet. That's fine. But this discussion of the base years is really important. Now we're merging the two discussions, which we've already talked a little bit about this, but the consolidation, we already alluded or mentioned the fact that you could have two consolidated groups now. I guess technically, potentially, three. And what I mean by that, let's say you had a group of RHCs, a group of really old RHCs that certainly they had 2020 as the base year. That's fine. But then let's say you had some of them that didn't have 2020, but they had some costs in 2021. That's another group. Potentially, it'd probably be extremely rare. Maybe you had a facility that started before 1/1/21 and again still didn't have any costs in a 12-month 2021 cost reporting period. You'd need to use the next available cost reporting period. So there might be another group. That'd be very rare, but the point I'm trying to make here, which we'll see in just a bit, is the groups. It's not just old versus new, grandfathered versus new. It's new, that's always going to be its own group, versus potentially multiple groups of consolidated grandfathered units if they have different base years. What CMS has clarified for us is that once a base year is calculated for a consolidated group, that's locked in and nothing can change. There might be another consolidated group with a different base year, and that's fine, but we have to track them by the base year that they've used. So we'll get to that here in a second. Let's take a look at the evolution of how this regulation came about. The original proposed rule for 2022, and by the way, this was in the physician fee schedule proposed rule, they were initially going to completely deny new RHCs the ability to file consolidated cost reports. And basically, if they had any new RHC, the whole group was out of luck. They were no longer allowed to consolidate. The finalized rule, when it came out after public comment, said, okay, you can have two separate consolidated groups, but I'm saying possibly more. There could very easily be three, a new group, and fairly easily, two grandfathered groups. We'll see that in just a bit. And as I said, there might even be another one, probably unlikely. This is page 65204 of this calendar year 2022 Physician Fee Schedule Federal Register. So the big question for these different years is how should we calculate the consolidated cap? And here's a quote from guidance that we received. If a group of consolidated RHCs are grandfathered, their cost-based rate should be established as a consolidated group. In other words, we take a look at all those costs, because keep in mind they've already been consolidated. We don't have detailed information about each RHC, so instead we use that consolidated cost data and establish that base rate. Again, the consolidated cap would be calculated by taking the total costs from all the RHCs consolidated divided by the total visits, again for all those RHCs, because that's all we have, from that base year cost report. And then that consolidated cap would be locked in and updated each year by that inflation factor. So you might have 2 or more lines on worksheet A. You might potentially have, again, a consolidated group of grandfathered, consolidated group of non-grandfathered. You might even decide for one of your groups not to even bother consolidating them at all. That should be consolidated. There's nothing wrong with that. It's not all or nothing anymore. It's all within a group or nothing, but with each group you could technically make your own decision. There is a serious edit in HFS, the cost reporting software, but again, serious is a little bit of a misnomer. It says consolidated reports should not have subscripts. Of course, that's not true anymore. There could be subscripts, 88.01, 88.02. That's perfectly fine. This one does need to be fixed, though. This is another serious edit. It says if worksheet S-8 line 13 is no, then line 13 column 2, of course, must be no. In other words, how many units do you have? That must be blank, actually. And if you're not consolidating, then there's no reason to use line 14 and subscripts, which are the listing of consolidated units. So that's a pretty logical one. But if this is yes, of course, you need to fill all that stuff out. So the problem that we asked CMS about, we got clarification on this. We had previous clarification initially that we used to issue letters for the base rates, but that assumed that the group had already been consolidated by the time of the base year cost report, which should have been the situation in most cases. But we found that there were some situations where RHCs were not consolidated until after the base year cost report. We've also found situations where they were consolidated, but then they've dropped consolidation after the base year cost report. Or there might be a change in the group altogether, and it's usually due to termination. It's not going to be due to a new RHC coming into that group, and we'll see why in just a bit. So that was the problem, and we've received an answer from CMS. The answer pretty clearly is whatever the consolidation status was as of that base cost reporting period in question, the 2020 or 2021, that cannot change after that fact. It's locked in because the rate was set using that data. And again, we might have a group of 2020, we might have a group of 2021 as well, but whatever rate was being used, that's locked in. And again, a lot of times that'll happen if you have an extra RHC that it's right toward the end of that time period. It was still before 1/1/21, but it hadn't been around for a long time and it didn't have any cost. So if you have RHCs that were not consolidated as of that 2020-2021 base rate calculation, those cannot be consolidated after 4/1/21. You're now locked out of it permanently because the rates were set individually and we can't merge them together. That's what CMS has clarified for us. If there's an RHC that drops for the consolidated group after that consolidated rate was calculated, again, generally due to termination, but perhaps not, they might be elsewhere, they and the surviving group are still bound to that original consolidated rate. That's the rate they were paid initially. That's the rate that was calculated for them. For every unit in that group, they have to continue to use it. If you have a situation, again, where there's a termed RHC, first of all, it doesn't matter for that RHC because they're gone, but for the rest of the group, we're not going to recalculate a new cost per visit. They're stuck with the original base rate, even though one of the units that comprise that base rate is no longer. It just doesn't change. New RHCs that are added to the provider cannot consolidate with a group unless they are all subject to the same national rate. So, of course, if we're talking a brand new RHC after 1/1/21, then they are going to be subject to the same national rate. So that's fine changing that consolidated group. You can add new RHCs to the original new group without any problem because they're all going to be paid the same anyways. And obviously the whole issue of let's say we're talking about a grandfathered group, there's a very short window of time when it could have been I don't even want to say new RHC, but a newer RHC, because again, it had to be in effect by 1/1/21. So that's the point. Once that rate is calculated, they're locked into it. No matter what move happens, nothing is going to be revised for the base rates. That's the point. So again, there could be possibly 2 or more groups of consolidated units, possibly 2 groups of grandfathered units, a group of new RHCs. It all depends on, we need to know what rates they're going to be using for their calculations. And that takes us to the end of our discussion. That's really what I wanted to talk about for this particular YouTube video. Hopefully this has helped to clarify some of the confusion behind the RHCs, consolidation, and the new base rates. Thank you for your time, and I look forward to talking to you in the next video.